In our day-to-day busy practice schedule, we all of us hear so many of non-specific complaints from the patient side. Most of the time, when we can't find the reason, we treated them with a placebo. But sometimes they are actually telling the truth, which we shouldn't overlook. Here I am going to tell you such a story that might shake you. A 61-year male patient came to my OPD with a complaint of floaters in his right eye for last 2 months, which appeared after the cataract surgery. He has a history of phacoemulsification in the right eye 2 months back elsewhere. He consulted many times with many physicians including VR specialists and diagnosed with a PVT by each of them. They advised him to use eye drop Nepafenac and assured that it will go over time. On examination, right eye having good pseudophakia with a mid-dilate pupil with the intact posterior capsular support. The best corrected visual acuity was 6/6. In the left eye, there was a NS3 cataract with a mid-dilate pupil with the best corrected visual acuity of 6/18. When I first examined the eye, I found nothing significant in the anterior and posterior segment at a glance. But the patient kept me saying, "Doctor, there is something like a lens is floating inside my eye and no one is listening to me." I asked him, "Do you know how does an IOL look like?" He said promptly, "Yes doc, there is a picture of lens outside in your clinic." I then realized I shouldn't be too prejudgmental, rather I should investigate more meticulously to find out the truth. And after thorough examination, I was astonished to see there was an intact IOL dangling at extreme periphery in the vitreous cavity in between 6 to 7 o'clock, and it might enter inside the eye through the zonular defect without producing a PC rent. So my plan was pars plana vitrectomy with PC IOL removal from the back and from the vitreous cavity with the secondary IOL implantation in the right eye. After making 3 ports, I started vitrectomy and noticed that the IOL was located at the extreme periphery in the inferior segment. After doing core vitrectomy, I injected triamcinolone acetate to stain the vitreous. Then PVD was induced very gently by the active suction of the cutter. All vitreous adhesions surrounding the IOL was removed. While doing a peripheral vitrectomy, I noticed that there was an area of retinal thinning present at the 7 o'clock. Then thorough base dissection was performed. My next step was to explant fast PCOIL from the back. I put viscoelastics in the bag and gently pulled out the IOL in the anterior chamber by the help of the Sinskey hook. Then a spiral tunnel was made and the first IOL was removed with the help of a McPherson forceps. Then, while trying to create a central capsulectomy in the posterior capsule, I realized that the pupil became too small to operate in a proper way, so I decided to introduce a pupil expander Gupta ring for more visualization. Then posterior capsulectomy was enlarged to create a sufficient opening for the explantation of the second foldable IOL from the vitreous cavity. With the help of max grip forceps, I grasped the haptic of IOL and brought it at the pupillary plane. Then using the handshake technique, the IOL was prolapsed through the PC opening and ultimately removed through the scleral tunnel. Then a multipiece IOL was placed in the sulcus. Optic capture was performed in the posterior capsule opening for better stability. Pupil expander was removed. Finally, I checked the posterior segment and did meticulous barrage laser in the thin retinal area. On the post-op day of 21, patient achieved the best corrected visual acuity of 6/6 in his right eye. So, to conclude, in life, we should always avoid judging others by our own level of perception. Rather, we should always remain open-minded. If you judge a book by its cover, you might miss out on an amazing story. Thank you.